research. Bone marrow aspirate, centrifuge, re-injection, just like Saki did. 2005 to 2006. Those were long nights. No effect. Part one. What was the next step? Well, what were some of the differences and how could we improve? The next step was to isolate and expand, because maybe the actual number of cells was deficient. So how in the world do you isolate and grow cells? You establish a cell lab, which is what we have. We have a state-of-the-art cell lab in Colorado. So from 2006 on, we started injecting expanded autologous bone marrow-derived cells. We injected them into the nucleus under fluoroscopic guidance. That too didn't work. Strike two. So what's so unique about the disc, the human disc? Saki clearly demonstrated. They have really poor blood supply. This is a vascular tissue. We also are bipeds. You walk on 2 feet. The rabbit has 4. There's a stark difference also between the animal stab model that Saki and other people have used versus that of the lumbar degenerative disc that we have. So there's critical differences between the two. What else is different? This is a hostile environment. It's hypoxic and acidotic. The nutrient supply is very fragile. In a patient with degenerative disc disease, the cells inside the nucleus are like a survivalist in the middle of the Sahara Desert. You've got to be on a special forces team to make it. So how in the world do you now improve survivability in such a hostile environment? Vascular. You increase the blood supply to that area. Based upon histology, there are 2 areas, not unlike the knee. There's the red zone and the white zone. There's the annulus, this is the nucleus. Those are the 2 zones. Special MRI will demonstrate that. What else can we do to improve the cell's viability? Well, now we've increased the vascular flow. A couple other things that we can do that will make a critical difference. Increase some growth factors. How about if we send the cells to like a special warfare camp, really tough survival training. So we can put them in a really tough condition and roll them out. So now we have some lean, tough guys going into a fairly nutrient-rich place. What else? How about the delivery? We need a special needle to get into the annulus. Well, we haven't had a needle like that before. But because of a remarkable alloy called nitinol, we've got a needle that can almost bend on itself. And we can actually put a needle in the annulus and put in cells. So now we've improved the conditions. We've expanded the number of our troops, our cells. And we've got a special way to get them. So let's look at our clinical results. These were the criteria that we've used. Single-level disc disease, less than 50% reduction in disc height. No previous surgery, no disc surgery, no central canal stenosis, and it can't be a herniation, it's got to be complete. I'm going to share with you some case examples. These will show 3 principal results. A reduction in the disc protrusion, improvement in the signal, and I took out that last slide. So. This is the first patient. She's a 31-year-old female that had failed conservative therapy as well as interventional therapy. She had no longer been able to be a model and was quite distressed about it. On the left, these are MRIs. You can see here is these L5S intervertebral disc, and the red arrow demonstrates a disc protrusion. These are the traversing nerve roots here, and there's a little pressure there. She had right-sided pain. She underwent injection of expanded cells, and this is 24 months after. The disc protrusion that was abutting this nerve root is gone. Clinically, she had resolution of her leg pain and a significant portion of her axial back. Here's before and after. Here's the disc. You can see the protrusion on the nerve. Afterwards, that protrusion of the L5S1 disc is no longer abutting the traversing nerve. This paralleled the clinical outcome as well. This is a welder who could no longer work despite being in very good condition. Here is his sagittal MRI. This is his L5S1 disc. You can see that the disc immediately above it, the L4-5, is bright in color. Pretty good height. When we compare discs, or when I compare discs with patients, I use a couple different criteria, and I always tell them to look at the disc height, the disc color, and what type of condition they are. So you can see this is a fairly normal disc with white coloration, meaning it's holding onto water. This L5S1 is shorter in stature. It's dark. It's no longer holding onto water. And it's got a significant disc protrusion. This is 7 months post-therapy. The protrusion is significantly reduced, which corresponded with this patient's clinical response. He's back well. He's also had a significant reduction in his oral narcotic parameters. This is an MRI improvement that also corresponded with clinical outcome. If you look at this is a sagittal, if you look at the L4-5 disc here, it's robust, it's white. That white is the same, it has the same color as the spinal fluid, which is white in this T2 signal. This white is water. Water is what allows the disc to provide its essential function. It's a shock absorber. If you take away some of that water, it doesn't function as well. Take away that water, the patient can have pain. And this is before therapy of the L5S1 disc. And after therapy, you see a partial return of the white, a partial return of a signal which is indicative of glycoproteins holding onto water into the nucleus. And this is a magnification. I hadn't seen this before in the literature. This is a cross-section of the same image, dark, prior to procedure, after the injection of mesenchymal stem cells with growth factors. You see a significant improvement in the quality of the disc. I know it's late. I wanted to share with you some of our results.